So we are learning about chronic lymphocytic leukemia. So it is a chronic condition, that is absolute lymphocyte count. So leukocyte count is normal for 1000 to 11,000 per microliter, that is 4 into 10 raised to 9, 11,000, 1.1 into 10 raised to 9. Here in this condition you get leukocyte count 5 into lymphocyte count is in this range 5 into 10 raised to 9 per ml for 3 months. So it is chronic. Okay, lymphocytic leukemia. So this lymphocyte will be in this range. Next, affected here B cells, abnormal proliferation of the immunocompetent B cells. And here males are more affected than females, and it is in elderly males. Okay, then next the causes can be deletion like 13q deletion and 17p deletion, then trisomy 21, then overexpression of some anti-apoptotic genes like BCL2 and ZAP70. Anti-apoptotic genes, when they are overactivated, cells proliferate. So ZAP70 protein and all positive means it is a bad prognosis. So patient is complaining of fatigue. Always patient has to sleep lying down. Fatigue, there is weight loss, night sweats. And in the blood you have RBC, WBC and platelet, all are involved. When RBC involved, anemia, comb positive hemolytic anemia. So autoimmune hemolytic anemia is Combs positive. When it involves bone marrow, it is Combs negative. Both you get in this condition. WBC involved infection like herpes zoster, pneumonia. Platelet is involved thrombocytopenia, petechiae, purpura, and there will be lymphadenopathy. And also hepatosplenomegaly. So the mass is increasing, will cause a compression, so early satiety. So this patient, how can you investigate is CBC. CBC, the TLC elevation, HB decreased, platelet decreased. And here B cell lymphocytes, we told it will be abnormal. Lymphocytes more than 5 into 10 raised to 9 for 3 months. Then peripheral smear. Peripheral smear shows when you prepare smears, some cells are damaged. So why they are damaged? They are easily fragile, that is called smudge cells. Then in the blood sometimes you can see spherical cells. That is actually hereditary spherocytosis. Then you can do a flow cytometry. You can look for CD receptors. So B cells, it's 19, 20, 21, 23 like that. Here you have an T cell marker here which is abnormal, that is CD5. It's important. Then next, look for immunoglobulin, it will be decreased. That's why patient gets infection. You can do a PET scan. Complete metabolic profile can be done. And the treatment. So treatment, if the patient is less than 65 years with no comorbidities, you can use FCR, rituximab, cyclophosphamide like that, fludarabine. If it is more than 65 years, rituximab can be given. When is the need for treatment? Need for treatment is, this is the bone. So it is the bone, you have bone marrow. When the bone marrow is failure, so that patient's RBC platelet count is decreased, anemia, decreased platelet. So in order to counter, spleen is producing RBC. Hepatosplenomegaly. Such massive splenomegaly will be there, that below the costal margin more than 6 cm. Then lymph nodes are also enlarged, massive lymph nodes more than 10 cm. Fever, high grade fever, that is around 100 degree Celsius. 100 degree Fahrenheit. Fever for more than 2 weeks. Or there is autoimmune hemolytic anemia, RBCs are getting destroyed by the antibody, which are not responsive to the steroids like that. So you start treatment. Treatment as we have told. And when you say remission, so everything should show improvement. What are the things that should show improvement? That is RBC and all should be, count should increase, hemoglobin should be at least 11, platelet should increase, should be more than 1 lakh, lymph node size should decrease, should be 1.5 cm, from 10 it has to reduce to 1.5, liver and spleen should be non-palpable, and bone marrow should be normocellular instead of acellular. Okay, absolute lymphocyte count has to decrease, all these things. So what are the complications? Infection. It is the most common cause of death. When you give treatment, so that is infection. Okay. When you give treatment, though it is curative for this leukemia, it can cause some other disease like skin, CA, prostate. That is important. Secondary malignancies can occur. Richter transformation is another thing. Richter transformation means this leukemia turn into non-Hodgkin's lymphoma. So in that case you have to do excision biopsy. Big lymph node will be there. So excision biopsy should be taken. Then, so which type of non-Hodgkin's lymphoma? Diffuse large B-cell lymphoma. Then what is another thing that can occur is autoantibodies are there that can cause autoimmune vasculitis, glomerulonephritis, autoimmune hemolytic anemia. So autoimmune hemolytic anemia will be Coombs positive because of hemolysis, bilirubin increase, LDH increase, haptoglobulin decrease like that. So for the types of this, you have staging, RAI, Savitsky staging. RAI Savitsky staging, it is low risk, intermediate risk, high risk. Low risk means lymphocytosis only. Lymphocytosis and lymph node, intermediate risk. High risk means bone marrow failure, so anemia, thrombocytopenia. Another staging is Binet. Binet, again the last staging is same. HB is low, platelet count is low. And the first staging, there is no anemia, no decrease in platelet count, only lymph node enlargement. So this is about CLL. CLL, these are the things to be known. CLL, what is the normal count, what is abnormal? This is abnormal. This is when you say it is chronic, 5 into 10 raised to 9 for 3 months. So it is affecting B cells, males, then 13q deletion, 17p, trisomy 21, that is Down syndrome. Then overexpression of BCL2, ZAP70. Fatigue, B symptoms will be there. Then affecting RBC, WBC and platelets. Then lymph node, hepatosplenomegaly and early satiety. Then CBC, these are the findings you get. So this we have already said. These are called smudge cells. This is RBC getting damaged. Hemolysis. Then flow cytometry, which are the markers. Then IgG decreased, PET scan can be done. Treatment, these are the treatment regimes. So this, what is the need for treatment related to bone marrow, related to RBC, platelets, lymph node, spleen, fever. So complication, most common cause of death is infection. Secondary malignancy can occur. Richter transformation, autoimmune changes, RAI, Savitsky staging and Binet staging.